missing the best.
Yeah. I like it a lot, but it's been ill for like I feel it. I was relatively ill for stuck on the first one. But if I it's so boring. Yeah, it's pretty boring. I very much apologize. I'm very sad that I picked it. When I first did it, I was like, all right, lymphedema. You never really think about it. You're just like, oh, I know we need to take care of it. I'm like, this would be a good topic. And then like a week into it, I'm like, all right, this is not really exciting at all. It's so boring.
You know the topic for my presentation? I wanted to name it low extremity amputation rehabilitation.
That's a mouthful.
It is a mouthful, but
I like it. Yeah, mine is all like. I feel like it's not really. Pretty much not what I intended, so that's what you did. Yeah. Sharp, man. Yeah, I like this one. I'm not anywhere. Punctual. Let's go back on. There we go.
All right, guys. So one announcement before we start. Camp Independent sign up this year. And has agreed that we can have 2 residents there this year throughout the whole week, but at least 2 residents on the first day. So there are 2 spots here, name and phone number. So resident 1 has to be a PGY2. All right. Resident 2 can be anybody, but you have to get permission. If you're a resident 2, like me and Ryan, who wants to go, you have to get permission from your rotation to go before you can for sure go. 2s, you can definitely go, so you can sign up. All right. So anybody can go. Yeah.
what's on rotation? How does that work?
What do you mean? You're excused.
Oh, really?
Yeah.
Like if I'm in Abington?
You're excused.
Oh, really?
Yes.
I will sign up for every day.
There's no,
No vacation, not a vacation, not a safe day, not regular day. You're excused.
How many days can you sign up for?
You can sign up for 1 day.
Oh, damn.
But, yeah, but at the 3, you can also sign up this year.
I'll be gone all week, guys. See ya.
All right, is that clear? All right, but if you're a 3, you want to go, you got to get permission. All right.
obviously.
And I also sent you an email with all the information for Camp Independence this morning, so you can look at it. It's also included in the back if you want to read it first. All right, so Mike, caring father, great husband to his wife, I think. All right, so he's going to talk about lymphedema, right?
Yep.
All right.
Before I start, though, I wanted to pass something along from the nurses. They just asked me to remind us when we do admissions, especially like on strokes and stuff, not to routinely do time voids. If they need them, go for it. If they don't need them, don't routinely click it. I was just asked that last week. But anyway, I'm going to talk about lymphedema today. Title is Lymphedema, Pathophysiology and Treatment Options, but I'll, of course, talk about a few more things as well. Thank you to Dr. Che for being my mentor and for Katie for breakfast. I initially decided to do this topic because I realized that every time somebody has lymphedema, all I kind of think of is Naomi and ask her to take care of it. And then I kind of stopped thinking about it from there. So I figured, why don't we do a little bit of an overview of lymphedema, because I know it's probably been a while since many of us have done a whole lot of stuff with it specifically. Brief outline, start with an introduction, epidemiology, anatomy, physiology and pathophysiology, diagnosis, morbidity, treatment, and then of course some references. So Merriam-Webster defines edema just as an abnormal excess accumulation of serous fluid in connective tissue or serous cavity. And of course, lymphedema is just edema due to faulty lymphatic drainage. Lymph contains tissue fluid, cells, and large extracellular molecules, which is why it's unable to be transported back by the venous system. You get lymphedema from one of two ways, both of which are due to extravasation of lymphatic fluid. It can be either in an inherited form, which is the lesser common way, or from a secondary form where you get damage to prior intact lymphatic system. It of course has a significant impact on patients' quality of life and function, which is the biggest thing for us here, because that's our whole goal in our career, is to have a positive impact on people's quality of life and physical function. So we all know what it looks like. Here's a picture of some lymphedema. Generally, it's painless. There can be some discomfort with it, sensations of heaviness. You can obviously have some skin issues with skin breakdown, skin drying out, and infections. It's insidiously progressive. Again, sensation of chronic heaviness. Appearance, again, is very concerning to the patients. Results in a lot of psychosocial issues. Early on, it's typically soft and can be pitting, which can make it slightly difficult to differentiate from other forms of edema, although the biggest thing that helps you differentiate early is lymphedema tends to be unilateral or affecting a single extremity, especially in the more common secondary form, whereas the other forms of edema, like heart failure, tend to be more bilateral. So that's a pretty easy clue early on. But chronically, it will become woody in texture, tissues become indurated and fibrotic, and it becomes non-pitting. So, you know, our understanding of lymphedema from its current understanding of pathophysiology and everything is relatively new, but it's been noted for quite a long time. This is a sculpture from about 35,000 years ago of Princess Ati of Egypt. I assume she's the one in the center with the really large extremities. All four extremities are pretty edematous in this person, so I would imagine that she had one of the inheritable forms. It'd be unusual to have lymphedema in all four extremities from a secondary cause. You can't really have an intro to any type of medical topic without mentioning Hippocrates. He was one of the first people to mention lymph nodes in the groin and axilla. He described lymphatic vessels as containing white blood, and he coined the term chyle, which, as I'm sure we've all heard before, comes from the Greek word chylos, meaning juice. And he referred to milky substance containing emulsified fats, free fatty acid, and mentioned it in the digestive system. This is an Italian physician, Dr. Aselli, and he was apparently credited with the discovery of lymphatic vessels. This is one of his illustrations of the digestive system. And he was noted to have discovered a large number of mesenteric cords that were extremely thin and white in a well-fed dog. And then he was one of the first people to apparently illustrate this. Fast forward 300 or so years, and we get into this most recent century where we started having a little bit more of a scientific understanding of exactly what lymph fluid is, what the lymphatic system is, and how important it is in multiple aspects of our body and well-being. It's pretty common. 140 to 250 million persons worldwide are affected, with 1 in 1,000 people in America being affected with lymphedema. Most often, it's secondary to axillary or inguinal radiation or lymphadenectomy in the U.S., or parasitic infections, which is the most common cause worldwide. We'll talk about those a little bit more in a second. And just to reiterate yet again, significant morbidity, both physically and psychologically, in these patients, and it's something that we really do need to pay attention to. So anatomy, if we remember way back when, the lymphatic system is composed of blind-ended capillaries, and they follow unidirectionally and parallel to the rest of the cardiovascular system. They're formed by a single layer of endothelial cells with fenestrations in between, as this beautiful picture shows. The little gap junctions here in between all the endothelial cells, allowing that interstitial fluid to drain into those capillaries and then be moved proximally back into the central circulation. Each cell is anchored to the extracellular matrix by an anchoring filament, which allows that particular cell in the whole lymphatic system to work with the mechanical forces of the extracellular matrix. So as tissues change in the extracellular matrix, as pressures change, it can affect the actual capillary and open and close those fenestrations. Interestingly, until recently, it was thought that there wasn't any lymphatic vessels in the brain, the spinal cord, in bone, cartilage, the retina. However, in looking this over, I'll still find multiple things that still cite that, but there's a lot of research coming out to show pretty strongly that there is evidence of lymphatic vessels in the central nervous system. So, as we recall, there's two main lymphatic drainage systems that drain back into the central nervous, or the central system. There's the right and the left lymphatic duct. The right is the smaller of the two, the left is the larger of the two, and the left is commonly just referred to as the lymphatic duct. So the right lymphatic duct drains the right head and neck, the right upper extremity, the right diaphragm, the right lung, the left lower lung, which isn't really well depicted in this picture, most of the heart and part of the right lobe of the liver. And then the left lymphatic duct drains pretty much the rest of the body. So this is a pretty major vessel. It's very important that it remains free of restriction and things to allow that lymphatic fluid to drain back into the central circulation. So it ascends from the abdomen through it starts at the cisterna chyli in the abdomen, traverses the thoracoabdominal diaphragm at the hiatus, at the aortic hiatus, the level T12, and then goes into the posterior mediastinum. It then continues to ascend cephalad. It comes through the thoracic inlet and then turns back around and come back down through the thoracic inlet to drain most commonly into the venous angle where the internal jugular vein meets the subclavian vein. And I didn't put it up there because it was really kind of wordy, but one of the studies that I was looking at was a study of a surgeon doing cadaveric dissections of, I believe it was like several hundred specimens, and he recorded the variations in where that duct actually drains, and it's pretty widespread. I think the most common variation, which was this one, was only in like the 36% to 40-some% range. So there's lots of variation, but the point I wanted to make here is that it does come up through and then back down through the thoracic inlet. So as I'll talk about later, from a treatment standpoint, that's an important area of potential restriction to flow. So it's extremely important. It helps to reabsorb the interstitial fluid. It's important in the immune response, and it helps participate in the digestive system. So in terms of reabsorbing that interstitial fluid, about 50 to 100% of the plasma exits into the interstitium every day. Most of that comes back in through the venous system, but that leaves a small percentage that is not able to be transported back to the central system by the venous system. And of course, if there was no way to get that back, you would become edematous pretty quickly. The remaining fluid has a molecular weight that's too large to pass through the venous capillaries, and that's where those fenestrations come into play with the lymphatic system. And again, based on the changes in hydrostatic and colloidal pressures and through that mechanical interaction between the extracellular matrix and the lymphatic vessels, that fluid in a normal functioning lymphatic system is able to be taken back up and returned to the central system. It participates in the immune response by channeling lymphocytes and antigen-presenting cells to the lymph nodes, and it's very active in inflammatory responses. And in the digestive tract, it's important in carrying fats and lipids in the form of chylomicrons back through lacteals, which are basically just specialized lymphatic vessels of the digestive system. So again, referring to these anchoring filaments, this is a pretty good picture here of the fenestrations are closed here, and then when you get an increase in pressure in that extracellular matrix, it ends up pulling on these anchoring filaments, and that opens up these gap junctions and allows that that fluid to drain into there. And you can see here that it's a blind end of the capillary, so everything should be flowing unidirectionally back into the central system, not like the rest of the cardiovascular system, which is a continuous flowing loop. So histologically, on the left side, we have a specimen with lymphedema, and on the right side, you have a normal specimen. This is an H&E stain, and you can see clearly lymphatic fluid stasis because we're talking about lymphedema, but it leads to chronic inflammation, and as it becomes more chronic, you end up with fibroadipose tissue deposition. And you get an increase in cellularity. You can see that by the increased staining on that left side, and you get a lot of perivascular inflammation and infiltrates, and you can start losing kind of the differentiation between the dermis and the epidermis. So again, like I mentioned earlier, it kind of comes in two categories. There's primary and secondary, and primary is the more rare form, anywhere from 1 to 10,000 to 1 to 100,000, depending on which source you're looking at. And primary comes in kind of 3 clinical subtypes. You have congenital, which starts, at birth or right around birth; lymphedema praeax, which starts around the time of puberty; and lymphedema tardae, which comes after the age of 35. So those categories are strictly based on basically age of presentation. As with most genetic things, somebody discovered something and named it after themselves. So there's a few named primary types of lymphedema. You have Milroy's, which is familial congenital lymphedema. So this is, of course, when you're very young or right at birth. It's a pretty small percentage, only 2% of cases. It's inherited autosomal dominantly. Results from heterozygous mutations of MSS-like tyrosine kinase 4, which encodes for VEGF-C, which is the vascular endothelial growth factor. And as we go on, you'll see the VEGF comes up in various forms along the way as multiple causative agents for these. Then there's Meigs disease, which is familial lymphedema praeax, so a little bit later onset, also autosomal dominant, variable penetrance. And then autosomal and sex-linked recessive forms are much less common. And I don't really go into those there because that's not my full emphasis in this talk. So the inherited forms can be secondary to just complete agenesis of the lymphatic vessels, hypoplasia of the lymphatic vessels, or obstruction from various causes of the lymphatic vessels. Being that they're inherited, they're also associated with multiple different inherited syndromes like Turner's, Klinefelter's, Noonan's, yellow nail, intestinal lymphangiectasia syndrome, and lymphangiomyomatosis. Again, won't be going into those in any more detail. Don't have that much time here. Interestingly, what I thought was interesting, at least, females are affected much more commonly than males, 4-to-1 ratio. So that has led people to believe that female sex hormones may have some type of play in the development of the lymphedema. And this was a pretty interesting study by Vinyaz et al. They analyzed 807 patients and collected data on patient characteristics of breast cancer treatment, prior history of cellulitis, body mass index, delay from cancer to onset, and duration of lymphedema. And what they found wasn't super surprising, but duration of lymphedema, BMI, which is a big thing in my mind, mastectomy, and past medical history cellulitis were associated with lymphedema volume. And then to back up the point I just made, they found that treatment with anti-estrogen drugs was negatively associated with lymphedema volume, and statistically significantly so. So this came from that study, and I've highlighted the statistically significant things. Again, body mass index, duration of lymphedema, past history of cellulitis, and mastectomy. And then at the bottom, you see the anti-estrogen drugs, and it's a negative association. So I found that pretty interesting. Then Mendola et al. Analyzed genetic mutations in 78 patients with familial primary lymphedema, and they found 7 different genes encoding molecules regulating VEGF and its downstream pathways in 36% of the inheritable forms. And they also analyzed 149 patients with sporadic primary lymphedema and found only 8% of those with those mutations. So, I'm sure there's still going to be more things coming out in the future, but there's multiple different genetic markers for potential primary lymphedema pathways. Again, another study, Newman et al. Found genetic changes in 22 patients in whom developed lymphedema within 18 months of breast cancer surgery, compared to 98 of those who did not. And they found single nucleotide polymorphisms, or SNPs, in VEGF2, VEGF3, and RORC. Again, were associated with lymphedema. But now we'll move on to secondary lymphedema, which I think is more common, what we're going to see more often, what we're going to deal with more often, and a bigger thing for us. So secondary, of course, comes from secondary damage to prior normal functioning lymphatic system. You get increased interstitial protein, changes in colloidal pressure, and osmotic movement of fluids into the interstitial space, and you end up with this insidiously progressive chronic cycle of swelling and inflammation and chronic changes. So filariasis is the most common cause worldwide. It's pretty uncommon in developed worlds, I've never seen a case of it. I'm not sure if anybody here has ever seen a case of it. Maybe at the end the attendings can voice in if they've seen anything. But it's more in the underdeveloped countries. It's due to infection of parasitic roundworm, Wuchereria vancrofti. 83 countries are endemic to the disease. Most of them are in Bangladesh, India, Indonesia, and Nigeria. And then there's a list of other countries here, which I won't bore you with. From our perspective, again, in the US and more developed countries, it's most often secondary to cancer workup, staging, treatment, be it surgery or radiation. It accounts for the substantial percentage, breast cancer does, a substantial percentage of upper extremity lymphedema. And about 1/3 of patients who have a lymph node dissection will develop lymphedema. And even just a sentinel lymph node biopsy, 5 to 7% of patients will develop lymphedema in that extremity that underwent the biopsy. Most patients who undergo biopsies or surgeries will develop some swelling after the surgery, but it's usually pretty self-limiting and resolves in 4 to 6 weeks. However, some people may develop delayed onset or longer progressive edema, which may develop into the chronic progressive lymphedema. The longest reported case that I saw was about 30 years after the patient had surgery. But of course, if you're looking at somebody 30 years down the road, you want to make sure there aren't other reasons for somebody to be having this edema, you know, whether it's a DVT, cellulitis, or other cause. Some other less common things: contact dermatitis, TB, rheumatoid arthritis, and factitious, which is kind of interesting. A quick side story: when I was an intern last year, we had a patient that was readmitted multiple times to us with extremity swelling and recurrent cellulitis of various extremities. And she kept saying, like, I don't know what's going on. And we ended up having dermatology come by and doing biopsies, and they found like one time it was like glass, another time it was plastic, and then we had site come by and they said it was a factitious disorder, and she was intentionally injecting herself. It was very interesting, very difficult case to treat. A point that I want to hit pretty hard on here is obesity. I think we should all be big proponents of healthy lifestyles and weight loss in our patients, and obesity is pretty significantly associated with an increased risk of developing lymphedema. Just from the obesity itself, but even more so after you've had an insult to the lymphatic system, like cancer treatment or staging. So this is referring to that same study I'd mentioned earlier. Vinyez et al. Mentioned a statistically significant association between obesity and the development of lymphedema with a p-value of 0.001. Heller et al. Showed that a BMI of 30 gives you, or greater than 30, gives you a 3-fold greater risk of developing lymphedema than somebody with a BMI under 25, which, of course, if you remember, 25 is the overweight cutoff, so that'd be people with a normal BMI. And they recommended using this as a pre-surgical counseling, a way to talk to patients about that increased risk and get them to engage in some lifestyle modifications to prevent the development of lymphedema. In comparison to obesity, statistically significant increased risk, patient age, tumor size, number of nodes harvested, and adjuvant chemotherapy was not found to be predictive of lymphedema, which I also found pretty interesting because I would not have thought that for most of those things. So BMI is kind of a big deal. Shaw et al. Did a randomized controlled trial with 12 weeks of nutritional counseling and dieting compared to those who did not do this. And they found that patient who lost weight had significant reductions in arm volumes and upper arm lymphedema compared to their non-dieting counterparts. So this is obviously a big problem. This is called massive localized lymphedema. It's, as the name would imply, a very large localized area of edema. It tends to occur in the very superly morbidly obese patients with an average BMI of 61, males to females 1:1. Average age of onset is 47. Another quick side story: when I was an undergrad, I would often see a gentleman on the bus taking public transportation with me who was very super morbidly obese. And I'm not sure that he had this because he was younger, he was in his 20s or so, but he had this huge flap of either this or just adipose tissue itself, but it would hang down below his knees. And watching him try to ambulate and sit on the bus, you know, it was kind of sad to see how much of an impact that had on this guy's life, just trying to go to class. So you can imagine what something like this would do. I mean, you could see this guy, he can't put his legs together, he's not going to be able to ambulate, he's not going to be able to sit. So this is something that clearly will need to be surgically excised to be treated. Typically involves the thigh, the lower abdomen, the penis to scrotum, the suprapubic area, vulva, distal leg, and arm. typically unilateral, but maybe bilateral, and again, has a very significant impact on patients' quality of life and function. Oops. So diagnosis, history, obviously like everything, from day one of medical school, history will give you the right answer about 90% of the time if you take a good history. If they have a history of some type of disruption to their lymphatic system, if a history of breast cancer with lymph node biopsy, with radiation, with surgery. Family history is important for the primary cases. If there's a family history of somebody with primary lymphedema, you're more likely to have primary lymphedema. And any of those associated syndromes like Klinefelter's or Turner's. Travel to endemic areas with filariasis, extreme obesity, cellulitis. Again, if somebody has intermittent or resolving swelling, it's unlikely to be lymphedema because it's more of a chronic progressive thing. I mean, obviously if you're treating it and it gets better after the treatment, that's one thing, but if it's on its own getting better and getting worse, unlikely to be lymphedema. So again, it typically begins as a mild pitting edema. May progress to significant non-pitting edema, and it almost always does if it's left untreated. Almost always affects the distal extremity, and again, so if the hand or the feet are unaffected, you may want to consider alternate diagnoses. And then swelling, inflammation, adipose deposition result in thickening of the skin, which leads to this stemmer sign, which basically, if you try to pinch the skin on the dorsum of the hand and you're unable to do so, or it's incredibly difficult to do so, it's a fairly sensitive and specific sign for lymphedema. Unfortunately, the source where I got this didn't actually give numbers on that. That's basically the wording they used. But as you can imagine, if you've seen lymphodematous limbs, that skin is pretty tough, and you're not going to be able to pinch that. A good way to quantify the amount of lymphedema is through a water dispersion test. I think we've all heard of it. I don't know if anybody has ever actually done it or seen anybody doing it, but essentially you place the limb in water and you measure the amount of displaced water, and then you would of course compare that to the contralateral unaffected limb, and the difference between the two is your volume of lymphedema. So staging and grading, this was kind of a frustrating thing to look up because there's so many different ways to do it, and there's overlap and there's discrepancies, and it seems like oftentimes we kind of just generally grade things in the clinical setting kind of based on like that CHF type of grading, and it's pretty subjective. But there are multiple actual standardized ways to grade it, and the International Society of Lymphology has a standard staging, which is kind of the typical for lymphedema. It goes stages 0 to 3. Stage 0 is latent lymphedema, so this is a person that has a risk factor for or has a history of disruption of lymphatic vessels, but doesn't have any measurable edema, but they may have sensations of the heaviness or easy fatigue with that extremity. So they present to you with some type of symptom, but they may not actually have edema. Whereas stage 1 is the spontaneously reversible lymphedema. This is the earlier stage lymphedema where it's typically pitting at this time. You can actually measure the amount of lymphedema here, and it typically does respond well to conservative therapy. And then stage 2 is the spontaneously irreversible lymphedema. This is kind of the next step up, and it starts to respond less to conservative therapy because at this point you're starting to get the fibroadipose deposition, and once that starts happening, that particular tissue becomes less amendable to therapy. And it looks like I lost my slide on the 3rd stage, but I've got this little chart here. And the 3rd stage is basically the next step where you would have lymphostatic elephantiasis, where it's just massive lymphedema, trophic changes to the skin, warty overgrowth. And then I included this one down here as well, this Campisi staging. This seemed to come up quite a bit with surgical staging. A lot of the surgical texts were referring to this, and it goes from 1 to 5, with 1 being broken down between A and B, but it essentially mirrors the exact same as the 0 to 3. They just kind of spaced it out a little bit, so I won't go through that in any detail. And then there's also grading, which is similar, but in a lot of the lymphedema texts, grading, they start putting in actual specific measurements. So the idea, the concept is pretty much the same, ranges from 1 to 4, so the same number of stages, just 1 to 4 instead of 0 to 3. 1, again, is mild. Difference in circumference is less than 4 centimeters. Typically, again, responds well to conservative therapies like elevation and compression and effleurage massage. Grade 2 goes to the non-pitting, more the next step up, size between greater than 4 and less than 6. And then grade 3 can be broken down into 3A and 3B, where 3B contains or affects 2 or more extremities. It may start to affect the trunk and the quadrant of that particular extremity. And again, the difference in circumference is greater than 6 centimeters. Start getting more issues with infections when you start getting to this point, because skin care becomes even more troublesome. And then again, grade 4 is when you start using the term elephantiasis, and it becomes massive. That second bullet there, of course, is referring to upper extremity lymphedema. It can be so bad that the face and head can be affected, and it can be so bad that ultrasound may not even be able to detect a pulse in these patients. So imaging, I'm just going to talk about briefly, because the diagnosis of lymphedema is largely a clinical diagnosis, but imaging can be used to figure out why you're having that lymphedema. So CT typically is the first go-to. You're typically looking for an obstructive lesion, whether it's from a neoplasm or otherwise. So it's quick, it's fast, it gives you what you need. Magnetic resonance imaging, as we know, it gives you much better clarity of the soft tissues, so that can be utilized as well. But of course, it's a longer test, it's more costly, and sometimes it's not necessary. Lymphoscintigraphy and lymphangiography, I've never actually seen anybody get these. They're not done very often. Excuse me. Lymphoscintigraphy is where they inject a radioactive isotope, and they follow that through. And then lymphangiography is just like any type of angiography. They inject a radio-opaque dye and then follow-up image to see what the vessels look like after that. Problems with these, of course, is that they subject the patient to radioactive substances. So if you don't need to, they often don't do that. I put this in here because I thought it was a pretty cool image. This is an MRI with STIR protocol using gadolinium contrast, with the left side of the screen being a pre and the right side being a post-gadolinium contrast study. So on the left, you've got, of course, the handy arrow sign there. You do already see some soft tissue edema there, as highlighted by the again the arrow, but the bright tissues there in that left ankle. And then after the gadolinium injection, you see in the right side of the left side of the image on B here, you see where that arrow sign is. There's just an abrupt stop to that vessel, so that vessel isn't making its way proximally. And of course, again, with the unidirectional nature of lymphatic systems, they're always going from distal to proximal. So you can see it's not going to allow that lymph fluid to travel proximally back to the central system. And then I believe it's a 15-minute delay over to this next picture over here on the far right of the screen. And you can just see uptake into the soft tissues all over the place with that gadolinium. So morbidity, again, it's a pretty dramatic process. It can have a lot of issues for the patient, both physically, psychologically. It's a pretty disfiguring process. Can result in difficulty using the extremity. Donning and doffing clothing can be just uncomfortable. Skin issues become a big problem, lots of infections, and lowered self-esteem. So Fu et al. Evaluated 12 quantitative studies and found statistically significant poor social well-being in persons with lymphedema related to sexuality, appearance, body image, social barriers. They found consistently negative social impact on financial burden, marginalization, perceived diminished sexuality, social isolation, public insensitivity, non-supportive work environment, perceived social abandonment, emotional disturbances, psychological distress, negative self-identity. Basically, this told me that as a society, we are incredibly mean people, because it sounds like we just like abandon everybody and make them feel just terrible about themselves. From a physical standpoint, recurrent infections becomes a dangerous, costly problem. These people have a lot of issues with skin breakdown, skin fissuring, skin drying out with superimposed infections. The typical infectious agents that you get with soft tissue infections are the same here, typically beta hemolytic strep and Staph aureus. As you can imagine, with the skin breakdown, the impaired immunosurveillance, decreased oxygen delivery, it's basically just a perfect setup for an infection. And then one of the more feared complications, although incredibly rare, is malignant conversion over to lymphangiosarcoma. But it's pretty rare. 0.07 to 0.45%. It's not a very common thing. So treatment, what do we do for these people? You know, like I mentioned, when I first started looking into this topic, I thought every time that somebody came to us, I would just ask Naomi to take care of it. And then I would go on with my day and not really have any clue what she was doing in the PT gym. So the most important thing always in my mind is to educate the patient. Educate them, you know, if it's a breast cancer patient who underwent biopsy or whatever treatment, you know, educate them about their risk factors and how to prevent the development of lymphedema after that procedure in the first place. Educate them about proper skin care techniques. Educate them about ways to avoid further insult or disruption or injury to the lymphatic system. Avoid extreme heat exposure, because this can cause vasodilation, which causes more edema, and then with the impaired lymphatics, you can't return that edema, so the swelling can be worse. Make sure the skin remains moist. Some people do need prophylactic antibiotics if they continue to have recurrent infections, but of course, if we can avoid it, we don't want to be showering these people with antibiotics. You know, another thing with like breast cancer survivors in the upper extremities, talk to them about sleeping positions and things, because if they have impaired lymph drainage in that upper extremity, you don't want them sleeping on their arm like this, because that's just going to further impair their lymphatic drainage. You know, avoid blood pressure cuffs in that arm, avoid needle sticks in that arm if you can. So complete decongestive therapy. This is the current international standard for lymphedema management. This is what I believe Naomi does in her secret cave over there. So specialized physical or occupational therapists do this. It's a pretty specialized effleurage technique. They do 2 phases. The first phase is kind of a reductive phase, and then move on to a maintenance phase. The reduction phase, you know, most therapy sessions last about an hour, so about 45 minutes of that hour. They'll do manual lymphatic drainage, which I'll talk about in just a minute. And they'll follow that up with compressive garments or compressive bandaging, and then educate the patients on remedial exercises to help use the muscle action to help continue to milk that lymphedema proximally. And then the compression bandages are typically left on for quite a while in this phase, because as you can imagine, if you take them off and you still have the damaged lymphatic vessels, the fluid may just reaccumulate. And then phase 2 begins after you get your maximum amount of reduction in lymphedema. This is a long-term maintenance program. Typically wear compression garments during the day and then compression bandages like ACE wraps at night. And you continue those remedial exercises to help keep that lymphedema down. And then you can go back and start manual lymphatic drainage again if needed, if it starts to creep back up on you. So what is manual lymphatic drainage? Highly specialized effleurage technique that you know, if we're trained in it, we can obviously do it, but the therapists typically do this. They do specific stroke pressures and sequence and orientation to help milk that fluid back and stimulate the intrinsic contractility of the lymphatic vessels. One thing to keep in mind is that the pressure is pretty light. You know, if you think about, if you're squeezing really hard, you're just going to compress down on those lymphatic vessels and actually, you know, act like a tourniquet almost as you're trying to do that. So you want to use a little bit lighter of a pressure. And you always want to start the treatment proximally, because you got to open up the proximal lymphatic channels to have a place for that distal fluid to then drain into. So you start proximally and then you work your way distally. All the while, the directionality of the actual effleurage technique is proximal. So open up the proximal, work your way distally, and go from there. After you do that, then of course you have to apply compression bandages. There's compression garments. I was going to put a picture in, but all the pictures were really ridiculous. They were all like these super skinny models and stuff, and I was just forgot about it. It wasn't actually like lymphedema people when I Googled for the compression garments. So they do have actual garments that you pull on. I'm sure we've all seen them. There are ACE wrapping techniques that you can do with, again, you have a distal to proximal compression gradient to help facilitate the proximal movement of that fluid. And then the garments early on are worn for more than 2 to 6 hours a day, but more in the long-term phase, people can wear them for 2 to 6 hours a day, but it varies from patient to patient depending on how quickly their fluid will reaccumulate. One thing to note, both effleurage technique and compression bandages should not be utilized when somebody has an active infection. So anytime you see somebody that has, you know, worsening swelling, erythema, pain, warmth, anything that would make you think that they have infection, you want to treat that infection and be cautious not to, cause hematogenous spread of that infection by making that worse with compression and effleurage at that time. So I'm a DO, so I'm kind of obligated to talk about osteopathic techniques. The therapists use these all the time. As DOs, we like to coin the term osteopathic, but it's not just regulated to us. The therapists do a lot of manual work that crosses over with the osteopathic techniques. But for the non-DOs, when we're talking about osteopathic techniques, we always use the term somatic dysfunction as our diagnostic coined term. And I think I like the way that they define it. I found that it's a pretty elegant way to basically be all-encompassing in diagnoses. And so they say impaired or altered function of related components of the somatic or body framework system, skeletal, arthrodial, myofascial structures, and the related vascular, lymphatic, and neural elements. So in one sentence, they basically grab the whole body and talk about basically any type of problem can affect anything else. But as it relates to treating lymphedema, I specifically wanted to talk about the diaphragms in the body and manual or myofascial release. So you have 4 effective diaphragms. We always think about our diaphragm as our thoraco-abdominal diaphragm, but you actually have 4 things that can act as diaphragms in the body. You have your tentorium cerebelli, you have, or cerebelli, excuse me, the thoracic inlet, which I was referring to earlier, the thoraco-abdominal diaphragm, and then the pelvic diaphragm. And these all work in a coordinated fashion, or at least they're supposed to effectively do their jobs. So the thoracic inlet, again, it's at the top of the thoracic cage. It's extremely important in terms of managing lymphedema because, again, the thoracic duct traverses that thoracic inlet as it goes cephalad and then turns around and comes back down through it again before it drains into the venous angle. So if you have any type of restriction there, be it arthrodial or myofascial, that's an area of potential restriction to flow. So it's something you want to open up these proximal areas of restriction before you start your treatment. So the thoracic inlet is bound by the body of T2, the medial margins of the first ribs, the posterior aspect of the manubrium, and the medial end of the clavicles. So I'm going to specifically talk about releases to these areas from a myofascial standpoint, but clearly talking about these boundaries here, if you have any type of dysfunction in the mobility of T1 or the first ribs, that's going to affect the myofascial structure. So if you don't address those dysfunctions or restrictions and you just do the myofascial release, it's very likely that that myofascial restriction will just come back without addressing those other problems. But I don't have enough time to talk about all those things, so we're just going to talk about the myofascial components. So one of the techniques for myofascial release of the thoracic inlet is the necklace technique. Depending on where you train, there's multiple ways to do basically all these techniques, but a very simple way to do it, the patient can be either seated or they can be supine, with the practitioner either standing behind if they're seated or at their head if they're supine. The practitioner basically puts their hands like this as a necklace fashion around the thoracic inlet, providing a gentle caudad pressure to engage those tissues. And then you put in this rotatory component here. You can either rotate towards the direction of ease, which would be an indirect technique, or to the direction of restriction, which would be a direct technique. And you ask the patient to take some big, deep breaths, and you'll feel that tissue tighten or loosen, and you engage those tissues depending on what you're feeling. And you continue to do that until you feel a release and you feel that thoracic inlet open up. The thoraco-abdominal diaphragm is incredibly important, not only because it's involved in our primary respiration, but also because the lymphatic duct goes through the aortic hiatus at the level of T12. So again, pay attention to the lower thoracic and the upper lumbar vertebrae and their restrictions. But you can imagine if there's restriction in the thoraco-abdominal diaphragm, then it's an easy area for compression of that lymphatic duct. So you want to make sure that's moving appropriately. And as we recall, when you inhale, the diaphragm moves inferiorly to create a negative intrathoracic pressure, and when you exhale, it moves superiorly, and you can have restrictions on how well that moves. So in order to do this, again, the patient can be either seated or supine. The practitioner will take one hand and put it underneath the costal margin to engage that diaphragm, and the other hand can be used to stabilize the lower rib cage. And you ask the patient again to take big deep breaths in and out. As the patient breathes in, that diaphragm should come down and engage your fingertips, and you should provide some resistance to that. And as the patient breathes out, you want to follow that diaphragm superiorly. And again, keep doing this until you feel that release. And that should hopefully open up that thoraco-abdominal diaphragm and allow the lymphatic drainage to move more unrestricted. Said all that already. And then the pelvic diaphragm, I have to admit, is not something that I've addressed often myself, but it's something that needs to be paid attention to. It's intimately related to the pelvis, the sacrum, and the pubis. So again, from a mechanical standpoint, you need to address innominate dysfunction, sacroiliac dysfunction, pubic dysfunction. But again, I don't have time for all that, so I'm just going to talk about the diaphragm release. It works just along the same fashion as with the thoraco-abdominal diaphragm. So when you take a big breath in, this diaphragm should descend, and as you breathe out, it should ascend along with the abdominal contents and with the thoraco-abdominal diaphragm. So to do this one, it's going to be a whole lot easier if the patient is lying supine. Have them flex their hips and their knees, and you sit down by their feet. You start with your fingers in contact with the medial side of the ischial tuberosity, and then you slide your fingers more cephalad to contact the pelvic diaphragm at the superior aspect of the ischiorectal fossa. And then the concept is exactly the same as the thoraco-abdominal diaphragm. When they breathe in, you resist that downward motion of the diaphragm, and when they breathe out, you follow that and encourage that cephalad movement of the pelvic diaphragm. And again, continue to do this until you feel a release. And then once these are all cleared up, you can do your effleurage techniques and things, but there's also lymphatic pump techniques, which I think are pretty good techniques. They're pretty powerful techniques. I'll talk about using the rib cage as well as using a pedal pump technique. So for the lymphatic pump using the rib cage, the patient is again supine. You stand at their head and you place your hands kind of over their superior chest like this with your thenar eminences just below the clavicles. You have them take a big deep breath in, you allow them to breathe in, and then as they're breathing out, you provide an oscillatory force down to compress the rib cage as they're breathing out. And at the end of exhalation, you hold there for a second, allow them to start breathing in, and then rapidly remove your hands. And it causes a very rapid, strong increase in negative intrathoracic pressure, which helps to facilitate that central movement of the lymphatic fluid back to the central system. And then the pedal pump technique, basically you stand at the patient's feet while they're lying supine, and you can dorsiflex and plantar flex in an oscillatory fashion their feet to help utilize that squeezing, pumping action of the lower extremities from a passive standpoint, because you're doing it, to allow proximal movement of that fluid. However, using these, you have to be very careful for medical comorbidities that would make them not tolerate rapid fluid movement shifts. So somebody with heart failure, you got to be really careful with, because these can actually mobilize pretty significant amounts of fluids pretty rapidly. So if you've got somebody with an EF of 15 or something, this may not be a technique that you really want to utilize, because you may throw them into pretty florid CHF by doing this. And then briefly, I'll talk about some surgical options. These are utilized when our conservative measures aren't effective for their lymphedema. So people that have really severe chronic lymphedema with a lot of fibroadipose tissue deposition, the conservative therapies are only going to be able to do so much. So that's when the surgical options come into play. And I'll just touch on them briefly because it's not our area of expertise, but you can do lymphatic vessel transplantation, which you basically just, it's like any type of other vessel transplantation. You take a patient's own lymphatic vessel and you transplant it to the area of need. Works well in areas where it's just a locally interrupted lymphatic vessel. So you can basically bypass that area of disruption. You can do a lymphatic venous anastomosis, where you take a vein and you anastomose lymphatic vessel to that vein. And then there's a vascularized lymph node transfer, which is a microsurgical technique where you take lymph nodes from healthy areas of the body, so maybe the contralateral area, and you implant it into the affected area. And then you anastomose arteries and veins to maintain local vascularity. But interestingly, they don't actually anastomose any lymphatic vessels here. Apparently, they spontaneously arise from the transferred lymph nodes. One of the things I found interesting about this technique is I'm curious, you know, where you harvest the other lymph nodes from sounds like you're setting them up for lymphedema there. So I found that to be pretty interesting that you would go that route. Here's another surgical technique I also found pretty interesting, especially for this patient in this picture, and I'll tell you why in a second. But you can also just excise this tissue, where they basically just go in and they cut out all this fibroadipose tissue that's been developing for some time, and they get rid of it. It's named after Sir Richard Henry Havelock Charles, who was the surgeon of King George V, who, to my knowledge, didn't have lymphedema, so I'm not sure why he got into this realm. But they basically just excise all that tissue. Spontuzzi et al. Evaluated 24 patients in whom they did this procedure, and they found that all patients achieved 100% reduction in lymphedema with no recurrences. 2 patients required reskin grafting, because after they do this, they do split thickness skin grafting. And all patients were able to resume normal functional activities after 2 months. And I just found that interesting because, you know, yeah, if you're going to cut it all out, then you're going to have 100% reduction. That kind of makes sense. But the cosmetic results, in my mind, are pretty terrible. And this person didn't have really bad lymphedema. I mean, I'm sure there are other people where their lymphedema is so bad it might be a viable option. But this particular patient, you know, her legs aren't incredibly different. And I think, you know, donning and doffing pants would be okay. I don't think a general person would really realize that. And I think her cosmetic outcome was way worse post-surgically than it did pre-surgically. So I just thought that was kind of interesting. So I threw her in there. Liposuction is another option. As I've mentioned multiple times, with this chronic lymphedema, you get fibroadipose deposition, and those adipose cells, you know, they're too big to go back through those fenestrations into functioning, even if you had functioning lymphatic drainage. And the other interesting thing is, you know, fat cells, they're not just stagnant cells. They're active endocrine organs. They're involved in inflammation, and they secrete cytokines and things. So, you know, it's something you don't really want sitting around for a long period of time. So you can do liposuction to these people and suck out that fibroadipose tissue. But again, afterwards, you still need to do lifelong compressive therapy, because doing the liposuction does not in any way fix their lymphatic drainage problem. It just gets rid of some of the downstream effects of that poor lymphatic drainage. So you have to do compression for a long time after that, or forever after that, so that it doesn't reaccumulate. So in conclusion, it's incredibly common, has a lot of significant morbidity, both from a psychological and a physical standpoint. Can be primary or secondary, primary being inherited, secondary being due to disruption of previously normal lymphatic vessels. Worldwide, filariasis is the most common cause, but for us in more developed nations, most common causes cancers and their related diagnostic workup and treatment. Lots of ways to treat it, but the biggest things are educate, start with conservative therapies, make sure that they're taking care of their skin, they're avoiding further insults to the lymphatic system, effleurage massage, you know, the CDT, the MLD, compressive bandaging. Osteopathic techniques are great adjuvants to that. Liposuction and various surgical techniques are available should patients not respond well to conservative measures. And then I put this in to show how I will feel later when I am done with this. Down. I don't know if you can hear it. It's like 30 seconds.
Oh, you're crazy, girl.
So that's why I get to go home tonight. It was kind of a broad overview and a refresher course, but yeah.
First off, the talk is great touch.
Thank you very much. Appreciate it. Just trying to impress you. That's all.
Is there a contraindication for getting those sticks?
You know, I didn't.
Or an increased risk of infection with
I didn't see anything specifically relating to that, so I might defer to the attendings. I would think if you're using a good clean technique, I would hope that the increased risk for infection would be pretty minimal. I think I just saw Dr. Cruz's hand pop up, so.
I think the major issue the thickness doesn't happen only of the skin. It is really the lipoderma sclerosis. It's from adipose, from subcutaneous all the way to the skin. That would be affected. So there will be some thickening. And in so doing, if you're doing sensory innovation or sensory testing, it may be hard with the skin, especially those deep sitting sensory nerves. And it may be hard, but if you do actually the needle exam, I don't see that there would be a direct contraindication. As long as you practice, of course, the basic cleaning the skin first before you stick the needle. In some cases, I do change the needle if I'm going to use it in multiple areas of the affected area. And again, that's more of my preference rather than the universal.
Do you use 5 needles for?
Really. You don't have to use it really 5 needles. You can do 2, okay? Or if you go, for example, 2 legs, you can use one needle on unaffected leg and then change the needle with the affected.
Yeah, if you're going from a dirty, quote unquote dirty area to another, so I'd start off with the area first. I know Sri doesn't use alcohol. This is an instance where I would use alcohol. And I don't care if you guys use 5 needles. It's less expensive than treatment. So.
Is that true? Some ones and check them on, but so
Yeah, sometimes.
It's a dissection. How does that differ from somebody just lymphedema on the road from these other causes that doesn't necessarily rest of section or something like that? It just it's the same concept. Don't have to slow yeah, just risk of infection.
So this issue came up during our E&G rotation too, and so it's not an absolute contraindication. So it's like it's just a relative contraindication.
It is. I mean, the point of the matter really is this is what I'm going to suggest to everybody, that you practice what you need to practice in terms of cleaning. This is one time that I would really emphasize cleaning the area first. And you're not going to poke it many times in the same area. A one-time poke, you can minimize, of course, the needle examination into a good amount of examination rather than keep on sticking the same myotomal area. You can probably minimize the chance of infection. But it's not an absolute indication.
You break out the data line and floor patients.
You don't have to go alcohol with this.
Yeah, so we get these every now and then with someone who, like we have breast cancer patients at Temple who come in with shoulder problems, and we'll still inject them. So a more posterior approach, and just like you would any other time, and really clean them up well. And they generally don't have a problem. Again, it's being mindful that you stand there and shut your mouth when you give the injection, and you give them a good shot. So.
Can you take them up?
So one more that I would like to make a comment on. It's good. It's a general description, but I think what you have to understand also from our standpoint, being a physiologist, would be how to apply it in the daily life, or how to apply that in the daily practice. It's nice to know about the examination, the surgery, and I'm not an osteopath, so I don't know how to do that. So that's good. I can get honorary one, doctor. Okay, but the point of the matter really is a good one that you pass the basic concept of educate the patient. Educate the patient, educate yourself too. What is really lymphedema? Lymphedema is not a typical edema that you can see because of whatever cardiac or renal problem. So please avoid giving any kind of medication, diuretics on these kind of cases. You could easily cause a vascular collapse in these kind of cases. It is not a problem of you might be probably depleted to begin with intravascularly. If you give actually fluid, or remove the fluid, you can cause more trouble to begin So educate yourself as much as possible. Know really the history. 90% on a history paper maybe a little bit more. I usually put it at 60% to make more accurate. And that's the reason why the 40% may be more physical examination, and the rest will be a small percentage will be the radiographic examination. And lastly, really advise your patient how to cope with it. Cope in terms of taking care of the extremity that's involved, and at the same time, the whole body itself. Know what is the condition causing this, and the last thing is, more prevention. You don't want really to cause more trouble than the effect of that, because of the fact that once you cause trouble in that, it can cause more death.
That was good.
Yes.
How's Paris? How's Paris?
Oh, you go to Paris.
Yeah, so I really went to Paris.
No.
Where'd you go?
Florida.
What? Yeah.
Yeah, either way, if you want to set up your computer or use ours, it's up to you.
Well,
Thanks for coming out.
oh, no problem. I appreciate the opportunity. So let me just, as long as I can get in, it'll be fine.
Yep. I mean, if, yeah. And then it should pop up. I don't know if you're familiar with maps.
I'm not.
Yeah, so
My
this-
kids use them.
Oh, really?
I've always been.
I'm a new user here. So you're it usually pops up here.
Sounds good.
Yep. Should be there.
Okay, thanks.
You used to come out here to lecture, or?
I haven't for a while.
It's been a while. Okay.
Yeah. So I've got handouts.
Okay, I can help with that if you like.
There's two different handouts.
Okay. So you're in the
Pittsburgh area,
right?
yep.
Yeah, I'm from that area. And I'm
All right.
planning on coming back that way.
Uh-huh. Where are you from?
Bethel Park.
Okay, very good.
I've been training out here at Temple for med school and residency and everything. So.
Very good. Okay, so that's
Yep.
the first one. This is the second.
Very good. Thank you.
Thank you.
Yes, she was. The words in. You got to sign out.
Why you're required? Of course, specifically that. What about this
Yeah, it was
I'm never gonna forget it.
Oh, sure, no, all these things.